Welcome everyone to the JACC Journal Club. I'm so proud for us to be able to have this second journal club, and it really reinforces the idea at JACC. What we're trying to do is figure out ways that we can help publish the best stuff, but ensure it gets to people, help engender conversations, learning, joint learning, community. It's all part of what we're trying to do. And I want to thank Taryn Myers at JACC for helping to support this and pull it together, Vivek and Megan for co-leading this, and all of our guests, and hope everyone has a great time today. But this is really the beginning of a lot more, where we're really going to be trying to deliver different kinds of content to people based off of what we publish in ways that people like to consume information and find fun, enjoyable, and learning, and ultimately, like I said, build the kind of community that we all like to be part of. So Vivek, let me hand this to you, and thank everyone for joining.
Thank you, Harlan, for your comments, and welcome everybody to JACC Journal Club. My name is Vivek Kulkarni. I'm the education editor for JACC. I'm going to give a brief overview of what we're doing here. This is the JACC Journal Club about tricuspid transcatheter interventions, which we're very excited to talk about. This was put together primarily by Megan Burke, who's going to take the lead here for me in a few minutes. Megan, you want to say hi?
Hi, everyone. Welcome.
So I will just give a brief overview. JACC Journal Club is an initiative that we started relatively recently, where we will be emphasizing and discussing interesting articles published in JACC. There's a QR code here on the left if you want to access the website. Many of the articles that we've created content for. We've created slides. We've had one prior live event, and this is our second live event. Many of them are organized around conferences. Some of them are not. We think it's an exciting new offering from JACC to allow people to dive a little more deeper into the articles that are published and into exciting topics. So please check out the website. This recording will actually be available on the website after it's over. So if there's people who were not able to come, they can hopefully watch and learn from there. Megan and I have no disclosures. And most exciting is our panel for today. I'd just like to introduce everybody and welcome them. So first, we'll start with Dr. Suzanne Arnold. Dr. Arnold is a professor of medicine at University of Missouri, Kansas City, a general cardiologist and an outcomes researcher at St. Luke's Mid-America Heart Institute. So Dr. Arnold, thank you very much for joining and welcome. Next is Dr. Gilbert Tang. Dr. Tang is professor of cardiovascular surgery and cardiology at Mount Sinai. He's an interventional surgeon and editor-in-chief also of JACC Case Reports. Dr. Tang, thank you for joining us.
Thank you. Great to be here.
Next is Dr. Paul Fiorilli. He's an assistant professor at University of Pennsylvania, structural interventional cardiologist, and co-director of the Transcatheter Valve Program at Penn, as well as director of structural heart disease. So, Dr. Fiorilli, welcome.
Thanks so much for having me.
And last but not least, Dr. Sajjad Sabir. He's an associate professor of medicine at Cooper Medical School, where I work, director of interventional echo and structural heart disease there. So thank you, Sajjad, for joining us.
Thank you. Happy to be here.
So just so we're all on the same page, I thought we would start with an outline of what we're going to do today. We're first going to discuss the TRISCEND II trial, followed by TRILUMINATE, and we'll go through the details of which trials specifically we're talking about. We're going to then have some time to talk about some shared methodological controversies that apply to both trials and hopefully have an interesting discussion about that. We'll then talk a little bit more clinically about a clinical approach to patient and procedure selection, both from the perspective of an echocardiographer and an interventionalist. And toward the end, we'll leave some time for a chat-based Q&A. So feel free to type questions in the chat as we go. We won't be addressing them in real time, but we'll keep monitoring the chat and get to them all at the end. I just ask that before typing in a question, please rename yourself, change your name in Zoom to include the following information: your name, training level, and the state that you're in if you're in the US, or the country that you're in if you're not in the US. So you can see my examples there below. That just helps us keep track of who's asking which questions and where people are coming from. So if you wouldn't mind doing that, we would really appreciate it. And with that, I will hand it over to Megan.
Thanks, Vivek, and welcome again to everyone, especially our discussants today. We are very lucky to have the first authors on these two really important trials in the tricuspid transcatheter intervention space. So as Vivek mentioned, we're going to be talking about the the 1-year results from the TRISCEND II pivotal trial, and then also the 1-year outcomes for the TRILUMINATE randomized cohort. And I would just like to say before we get into these two trials, because we're going to get in a little bit into the nitty gritty, both to Drs. Arnold and Tang, please feel free to jump in if I misrepresent or if you have anything to add as I go through the data from both of these. And also just to say thank you both and to your co-authors for doing these trials. They're so important and so difficult to do, huge lift, but are really essential to moving the field forward. So I really commend both of you on these two very successful trials. Okay, so just to start with a little bit of background for those who don't think as much about TR, I think so tricuspid regurgitation, the tricuspid valve, has often been referred to as the quote unquote forgotten valve. Often felt to be in many situations secondary to left-sided disease, that patients are less susceptible to poor outcomes with tricuspid regurgitation than they are to left-sided valve disease. The more and more we learn about the tricuspid valve and tricuspid regurgitation, it turns out that that's really not true. So tricuspid regurgitation is associated with increased morbidity and mortality, and this has been shown time and time again. It's been shown in healthy populations, in patients without other valve disease. That's been shown in the UK Biobank cohort, in multiple echo cohorts. It's been shown that even if you adjust for RV systolic pressure, the presence of atrial fibrillation, the presence of left heart disease, these patients have increased morbidity and mortality as well as independent of pulmonary hypertension and right heart failure. So it really goes to show that that TR in and of itself is really an important driver of morbidity and mortality. And thankfully, we now have these minimally invasive transcatheter interventions, and with those interventions, we now have both more treatment options, and with that comes the opportunity to better study this disease, as well as really the function of the right heart and the pathology of the right heart and how we can better manage these patients. So the first trial we're going to get into are the 1-year results from the TRISCEND II pivotal trial, looking at the quality of life after transcatheter tricuspid valve replacement, or TTVR, as we'll say. So the trial design, this was a prospective, multi-center, open-label, randomized trial of transcatheter tricuspid valve replacement with the EVOQUE valve system, in addition to optimal medical therapy, compared to optimal medical therapy alone in patients who had symptomatic severe or greater tricuspid regurgitation. The study was designed with a 2-to-1 randomization, so twice as many patients were randomized to get the device than the medical therapy arm. And then importantly, the primary endpoint was a hierarchical composite primary endpoint. And so this included 1-year all-cause mortality, the need for RVAD, heart transplant or tricuspid valve intervention, heart failure hospitalization, Kansas City cardiomyopathy questionnaire improvement greater than 10 points, and then also New York Heart Association class greater than 1 class improvement, or 6-minute walk improvement greater than 30 meters. And so we'll talk a little bit more about that endpoint, that composite endpoint. So just to look at the baseline characteristics here, as you can see, for the most part, the characteristics of the demographics of these patients were the same in between both groups. I would just like to highlight, although it was not statistically different, the optimal medical therapy alone arm did have a slightly higher number of patients with more severe TR than the device arm, although again, not statistically significant. So looking here at the central illustration and really sort of getting at the crux of the outcomes here, you can see this is looking at disease-specific health status over 1 year. So the blue line represents the device arm, the green line, the optimal medical therapy alone arm. And what you can see are the predicted mean health status scores between the group differences. The arrow bars represent the 95% confidence interval. And you can see here that the improvement, the average health score started to improve at 30 days. further improved, and you can see how that separates out at 6 months, and then that was sustained to 1 year. And you can see the point differences in that Kansas City Cardiomyopathy Questionnaire score between the two groups. And then here you can see, I found this really interesting, the proportions of patients that had improvements in their quality of life as measured by the Kansas City Cardiomyopathy Questionnaire who were alive. And it's broken down between patients who are alive with moderate improvement in each group, patients who are alive with large improvement. Moderate improvement is defined as an increase in that questionnaire by 10 points. Large improvement is an increase in that questionnaire by 20 points. And then the third group, you can see the patients who were alive and well. And you can see the difference between in blue, the device arm, and then in green, the medical therapy alone arm. And what you can see is, the patients who were alive and well was much higher in the device arm than in the medical therapy arm. And when you look at specifically moderate and large improvement, that was also true. And here you can see that the number needed to treat was relatively small. And then again, here you can see the treatment comparison between the two groups. And this is the proportions of all patients with different outcomes between the two. So you can see the proportion of patients who were dead, who had worse outcomes, and then if they had no change, small, moderate, or large change. And you can see really the difference. The patients in the device plus medical therapy arm who had at least a small change was over 60%, compared to a little less than 40% in the optimal medical therapy group. And then the last slide, result slide I wanted to highlight here is looking at the effect of the device plus medical therapy compared to medical therapy alone among key patient subgroups. So there was no difference when you looked at the interaction with age, sex, or age or sex. But when you look at, thanks, Vivek. When you look at baseline TR severity, there was a difference between the groups. So if you had worse TR at baseline, you can see here, you were more likely to have a larger increase in your Kansas City Cardiomyopathy Questionnaire score. And then the same was true with 6-minute walk distance, and right ventricular function is assessed on echo by fractional area change. Interestingly, there was no difference when you looked at cardiac index, pulmonary hypertension, or left ventricular function.
Dr. Arnold, I actually had a question here, if you wouldn't mind. I'm wondering if you could tell us a little bit more about what you think is the relationship between RV function and response in terms of quality of life. The reason I ask that is that looking at the secondary analysis subgroups, fractional area change was significant, but TAPSE, cardiac index, and pulmonary hypertension were not. So I'm curious how you put that together.
Yeah, so I think it's complicated, and I think our understanding of the RV is obviously evolving. I think that if you look at in the TRILUMINATE study, cardiac index, that interaction was significant, and we sort of tie that into RV function as well. I think that one thing is that patients that had moderate to severe pulmonary hypertension were essentially excluded from both studies. And so this idea of pulmonary hypertension is not, it's yes, no, but it's not severe pulmonary hypertension. So I don't think I would make a huge, I wouldn't make a huge deal about that. I think that TTVR does impact RV function, at least certainly in the acute setting. And so my feeling is that if the RV function is low, those patients are just not going to recover as well from the procedure. And I think you do see that as well with TTR, just probably not as much than with the insult of the valve replacement.
Great.
And Dr. Arnold, I was wondering if you could also comment, the differential between baseline severity and how that impacts the quality of life outcomes that you saw here in the study relative to the TRILUMINATE study, if you want to comment on that.
Yeah, no, I think that this fits really well with what the data that we have from TRILUMINATE, as well as China TriQual, which was this study we did that was funded by the FDA, where it basically has to do with the degree of TR reduction. And so the more TR reduction that you have, the greater health status benefit. And so with TTVR, which is slightly different than with TTR, the more TR that you have at baseline, the greater is very directly related to the degree of TR reduction. And so more TR reduction, greater health status benefit.
Great, thank you so much. And every study does have its limitations, and this study did, although they were minimized as much as I think was possible. So the study was randomized, but was unblinded without a sham control. The durability of the device and the outcomes beyond 1 year remains unknown. So we'll have to follow up and see what happens with these patients beyond 1 year. And then it's also worth saying that the subgroup analysis is true of almost any study, may be underpowered, especially in this study in the optimal medical therapy group, since there were half as many patients randomized to that group. And then just to review, to summarize here for everyone. So this was the first randomized trial of transcatheter tricuspid valve replacement. The previous studies were not randomized trials. And then in patients with symptomatic, at least severe tricuspid regurgitation, valve replacement plus optimal medical therapy resulted in improved symptoms and quality of life, and that this was sustained at 1 year. And importantly, there were no statistically significant differences in mortality or heart failure hospitalization. But greater benefit was seen in patients with preserved RV function and better baseline functional status. And then also importantly, as Dr. Arnold mentioned, that the magnitude of benefit increased with baseline TR severity, suggesting that which allows for more TR reduction, which is really what we're getting at here. Okay, so next we're going to move on to talking about the TRILUMINATE 1 year outcome. So as opposed to transcatheter valve replacement, we're talking here about transcatheter edge-to-edge repair. So slightly different method of reducing TR. Okay, so this trial design was a little bit different. This was also prospective, multi-center, open label and randomized trial. This was done, the tricuspid edge-to-edge repair system was, in this study was TriClip. And the trial was, the patients were randomized to TriClip or optimal medical therapy alone. And again, these patients had symptomatic severe or greater TR. The patients were randomized in a 1-to-1 fashion. There was adaptive sample size re-estimation as the study went on. Which, as I'm not a statistician, I will not comment on that. Maybe I'll leave that to Dr. Tang if he would like to comment. And then importantly, this also had a hierarchical composite endpoint, which was all-cause mortality or tricuspid valve intervention, heart failure hospitalization, and then improvement in the Kansas City Cardiomyopathy Questionnaire by 15 points at 1 year. Okay, so in figure 1 here, what you can see is the TR severity following the intervention with a tricuspid end-to-end repair. So you can see there was a significant reduction in TR severity that was observed at 30 days and sustained through 1 year for subjects that were treated with a device. You can see the device group on the left at baseline 30 days and 1 year, and the control group on the right there with where there was no significant improvements in TR severity in that group. And you can see the color-coded TR severity, mild, moderate, severe, massive, and torrential. And you can really see just how many patients had reduction, over 50% had TR that was mild at 1 year. And then I think this graph is really important, I think, especially for the naysayers of the hierarchical endpoint, primary endpoint, because when you look at this, so again, I hopefully I don't butcher this too much in my non-statistician understanding, but when you're doing these hierarchical primary endpoints, first you see, does the first endpoint meet? And if it does and it's significant, great. If not, then you move on to the next. And so the first one is death or tricuspid valve surgery. And here you can see, if you're free from that event, you have a quote unquote win. And so you can see the number of wins in the device arm compared to the control arm for death or tricuspid valve surgery. And you can see that the device arm had more wins than the control group. It just was not statistically significant. The same was true for heart failure hospitalization. And then when you get to the quality of life outcomes, you can see that there's now statistically different numbers of wins compared between the two groups. And when you add up the total wins for this composite primary endpoint in the device group compared to the control arm, you can see that win ratio is significant, right? So that the ratio of 1.8 tells you that the device subjects were 84% more likely to have a better outcome following treatment with T-TIR than the control subjects. And then here you can see, again, this is just depicting that between the device and the control arm, there was no statistically significant difference in freedom from death or tricuspid valve surgery at 1 year between the two groups. It was not statistically significant when you looked at heart failure hospitalization, although there was a trend towards fewer hospitalizations in the device arm. And then you can see all the way on the right, the improvement in the quality of life outcome score was statistically significant. And then the last result slide I wanted to show here was the change in the quality of life score in the 6-minute walk distance if you look at the magnitude of TR reduction at 1 year in both the device and the control subjects. So the important thing I think to take away from this is that the patients in the control arm who were just getting medical therapy, who also had improvement in the degree of TR, had improvement in their quality of life. So although there was no sham control here, I think this helps speak to the fact that if you have improvement in TR, regardless of mechanism, you're going to have improvement in your quality of life. Although it's interestingly, that improvement was greater in the device arm, even for the same grade improvement in TR. So I'm going to stop there. Dr. Tang, I don't know if you want to comment maybe on the degree of TR reduction between the two groups and the impact on the quality of life outcomes and how you sort of interpret that.
Yeah, no, thank you for having me here. I think the message here for this particular slide and the data is that you want to reduce the TR as much as possible, although, the endpoint was moderate TR or less, which, saw a favorable outcomes in terms of improvement in quality of life. But you can see that clearly here that the more grade reduction you get, the better patient will feel. And remember, this trial is the first time that actually classified the tricuspid regurgitation severity into 5 grades. So before it was, per ACC/AHA guidelines, was mild, moderate, and severe. But we find that quantitatively, in terms of severe TL, that's actually further than that, in terms of the quantification. So by breaking down the severe category further into massive and torrential, so we've had patients, for example, may not get to moderate TR, but of course this patient population is specifically for the randomized control group, so they would have to be expected to be moderate or less. So even from, let's say, torrential to severe or massive to moderate has a benefit on these patients from a quality of life standpoint. And you can see that here on the medical side, that did not really translate as much in terms of the TR improvement. So on medical therapy alone, you really have to get to at least 2 grades to get that improvement.
Can I also ask Dr. Tang, one of the things that caught my eye was even in the control group, there were 23 patients whose TR improved by more than 2 grades. I'm curious what you think of that is, because presumably all of these patients have been optimally medically treated already and had pretty strict enrollment criteria. So I'm curious what you think of that.
No, absolutely. I mean, as you know, the RV is very compliant and TR can be very dynamic. So, patients on different variable regimen of diuretics and optimal medical therapy can, have TR improvement. So we're not saying that, stop the medications and stop the optimal medical therapy. That is important to maintain even after you get treatment. So certainly treatment alone helped you. And these patients likely probably have less severe degree of TR and less RV dysfunction, as Suzanne mentioned. And so they likely can improve as you can maintain the aggressive diuretic regimen. The challenge we face in reality, remember, this is a very much a control trial, right? They have closely monitored, they closely follow up, is to how tightly they can be controlled in the community. Because what we've seen now in real life practice is that, they just not able to maintain that degree of tight control because they have difficulty access to proper follow-up because, the community cardiology or internist practice are very busy. They, even though you want them to be followed every few months, they just practically not able to do that. And so what we've done actually, when we follow with these patients, we ask them to get a bathroom scale because they are their own best caregivers and caretakers. And we ask their family, they weight themselves, regularly. And I think for us, the volume status by body weight, which I know it's not the most accurate to measure, but that's a good surrogate, is kind of a marker to see, how much volume they've gained or how much volume they've lost. So by just even doing that, they're able to track more closely how well they're doing in terms of their volume status and maintain their volume status that way.
Thank you, Dr. Tang. That's a really helpful insight. So just to go over, before we finish up talking about the study, there are a few limitations as were outlined by Dr. Tang and other authors. So this follow-up was during the COVID-19 pandemic. I think we all know the challenges of following up any patients during that time. As mentioned, the study was unblinded and lack of sham control, similar to the TRISCEND II trial. And then, as always, there's some statistical limitations for the interaction analyses, especially between the enrollment phases. And then just to summarize the general conclusion, so T-tier with TriClip is safe and effective. The primary endpoint was driven by improvements in quality of life and health status. The changes in quality of life were associated with the degree of TR reduction, and that heart failure hospitalization in the second enrollment phase favored T-tier, although was not statistically significant. So more to come on that. And then now that we've sort of, outlined both of these trials and understand, how they were run and what they showed, we wanted to talk a little bit about the shared methodological controversies that came up in both of these studies. So to both of our authors, I would love to know your opinions, and for anyone else who wants to chime in, the use of quality of life outcomes as a hard endpoint, I think, has been controversial. I think there are a lot of people who are proponents about how important quality of life outcomes are in trials. And then, I think there are certainly naysayers who feel like hard outcomes like hospitalization or mortality are really, the most important. So I think that is something that, is really interesting, especially in the design of these trials and how the quality of life outcomes were highlighted, and what they even say about heart failure symptoms. And then secondly, to discuss the lack of sham control, the possibility, I'm not sure that these trials could even be done with a sham control, but obviously, and no study is 100% without bias, but I would love to hear more from both of our authors about how the studies were designed with these issues in mind.
Maybe the last question, it was brought up in an associated editorial that, placebo effect is a significant concern here with the lack of a sham control. So maybe Dr. Arnold, we could start with you if you want to just, weigh in on some of these questions and how you interpret them.
Yeah, and unfortunately, there's a lot to unpack here, so I could comment on all of these. So first, I would like to say that hospitalization, I would not necessarily call that a hard outcome. There are a lot of things that impact hospitalization involving the decisions to hospitalize the patient. So there's issues even with a hospitalization endpoint. I think that if you look at the KCCQ across any study that we have looked at, patients who have improvements in KCCQ have reduction in their risk of heart failure, hospitalization, mortality. That was true in TRILUMINATE, that was true in TRISCEND, that was true in TriQual. And the point estimates that we saw were very similar to what we've seen in MTIR. So they were very similar to COAPT. I think that the trials were very underpowered to show mortality and heart failure hospitalization. So even if we did kind of back of the envelope calculations for both trials, and they were very underpowered just based on the event rates in the tricuspid patients. So I don't have an issue with the KCCQ here. I think that the question of the second question of being a placebo effect or could you do a sham? I think there's a couple things here that are important. I think that one thing that's important to realize is that these were all controlled studies. So they were all randomized studies. And the fact that these were open labels is important, and a sham is always ideal. But there's a lot of things that happen in a trial that are not just placebo. So everybody always assumes that everything that happens in a sham arm is a placebo effect. But there are a lot of things that happen with being in a part of a trial, all the close follow-up, all of those things that happen that can also impact outcomes. So it's incredibly important to have a control arm. The fact that these were compared against a control arm was very important. Is there a part of this being a placebo effect with a patient-reported outcome? Probably there's some, but there is so much work that we have done looking at a couple of things. One, it's a disease-specific health status measure. It's been validated in TR patients. So I feel like it really does capture the symptoms and function of these patients with severe tricuspid regurgitation. That's less likely to be open to bias compared to kind of a generic health status measure. I think the magnitude, the duration of effect really does favor this not just being placebo. The other thing is the correlation with TR reduction. So I think that really, you're correlating it with an underlying physiologic change in the patients. I think that really does support that. And then the final thing is that, it correlates with kind of risk of heart failure, hospitalization, and mortality. I do think you could do a sham study with TTR. I think that that's possible. I think it would be challenging in the US for sure, but I do think that's possible. I don't think that you could probably do that with transcatheter valve replacement. I think that intervention is too big, too invasive, too much of, kind of a counter between side effects and complications. But I think it would be really interesting to do a sham with TTR. I think it's possible. I don't know if it's necessary, but with all of this controversy around it, maybe we think about it.
Thank you. Dr. Tang, would you like to weigh in as well?
No, I agree with Suzanne's comment about, this is not a placebo effect because you can see the magnitude of TR reduction does correlate to KCCQ score improvements. Otherwise, you wouldn't see that in both arms, right? As like you would have seen only in one arm potentially if you really think about that. The second point I want to mention, being a surgeon, we know that, tricuspid regurgitation, yes, it's got a poor prognosis, but it's not as acute as mitral. Right, you've seen the mitral trial that they really see the mortality difference start to separate 1 to 2 years. You saw the COAPT trial. You now see reshape HF with the differences in mortality and hospitalization. But patients with TR are reasonably well compensated, and you see that here, right? And that's why you don't see the mortality difference between the medical therapy arm and both repairing the tricuspid valve and replacing the tricuspid valve. We'll have to see what it shows at 2 years and beyond, and not to give a spoiler alert, but ACC 2025 in a month from now, the late breaker will be to TRILUMINATE. The 2-year outcomes trial will be presented at the ACC. So we'll look forward to seeing what the outcomes will be at 2 years compared to 1 year. But I would, again, caution to say that, well, there's no hard endpoint or mortality difference in these two trials that we should just write off the therapy. I think, there are other surrogate things that we see at the patient clinic, and I'm sure many of you at your who are watching this webinar has attested to and related to, that the patients come back and saying, they might still have residual TR with TTR, or they might have no TR left, and they can tell you that, I don't have to go to the bathroom in the middle of the night, every night now. So that's a big quality of life difference. I mean, imagine yourself having to do that, your quality of life wouldn't be so good either. So I think there's some other ancillary benefits by just having improvement in TR that allows them to have that quality of life improvement that you see in both trials.
Great. Thank you very much. And we're going to move on from this topic now, but for anyone who wants to read more about it, the citation is at the bottom for the editorial that raises some of these controversies. We're going to move on now to something a little more clinical, which is patient and procedure selection. So I'd like to start with Dr. Sabir to get an interventional echocardiographer's approach. Knowing that we have these two options for TR, how do you evaluate patients? I mean, valve anatomy is also part of it, but maybe could you talk a little bit about how you assess RV size and function? Are there specific patient comorbidities that direct you one way or the other? Are there specific hemodynamic parameters? So we'll start with Dr. Sabir, and then we'll get Dr. Fiorilli after that.
Yeah, absolutely. Thank you for having me here again. It's nice to have two options, repair and replacement option. And I think it's really a team-based approach to determine, which therapy would serve best a specific patient. But the most important factor really is understanding the strengths and limitations of each device, what each device does, and then looking at the imaging, primarily echo would be where you would start with, to understand what you have. Actually listed many of the things on there. What's the mechanism of tricuspid regurg? Is it atrial functional? Is it ventricular functional? Is it primary, secondary? Are there leads to the device? For those who may not be familiar, edge-to-edge repair, as the name suggests, you're trying to bring the two leaflets together. What is that distance or gap between the two leaflets that you're trying to approximate? Because the arms can only reach so far apart. How extensive the leakage is, where the leakage is. That piece sounds simple, but is very important, and you gather that information from echo imaging, for example.
And also specifically to that point about valve anatomy, this figure was also in our tricuspid issue. This talks only about anatomy, not any of the other factors that may be important, but a lot of the things you mentioned in here, Dr. Sabir.
Yeah, no, I agree. And also we know from surgical colleagues that, tricuspid valve can have multiple leaflets. You can have as few as 2 and as many as 7 scallops or leaflets, but that piece is also important to know that. So that's the anatomic perspective. But I also argue, as you learned, RV function is super important. It could be very difficult to determine RV function assessment. In determining if you have a choice between edge-to-edge repair versus replacement, and you have a really bad right ventricle, I would favor edge-to-edge repair for the reason that we mentioned earlier, because elimination of the RV evoked or valve replacement does a phenomenal job of getting rid of tricuspid regurg. But for a failing ventricle, as you can imagine, that sudden increase in afterload could be very challenging to handle. So personally, I would favor in that setting an edge-to-edge repair option as opposed to completely replacing the valve. Also with the evoke, you have to be anticoagulated. We don't know how long. For right now, we think, indefinitely until we sort of get a good sense of how long that duration is. That could be a challenge for these elderly patients. So there are a number of different factors you have to keep in mind. Additionally, pacemaker need is pretty high pacemaker rate with evoke. When it comes to safety, edge-to-edge repair is certainly a lot safer than evoke, but you have to really individualize the therapy. So you have to look at the clinical piece along with the imaging piece to make that decision.
Sorry about that. Great. Thank you very much, Dr. Sabir. Dr. Fiorilli, from the perspective of an interventional cardiologist who's doing these procedures and putting in these devices all the time, what else do you have to add about patient selection or procedure selection? In particular, I'm curious your thoughts on the last part here about using right heart cath parameters and, evaluating hemodynamically.
Yeah, absolutely. Thank you so much for having me. This has really been a great discussion, and we're so lucky to have to have the investigators, the principal investigators here with us. So thank you for going through everything. You know, I was recently at a conference, and a very prominent cardiologist made a comment that we're seeing an epidemic of TR patients in the office now. And as it, of course, is an acute discovery of a chronic problem. But it's true. I mean, we're seeing patients sort of falling out of the woodwork with severe tricuspid regurgitation or greater and highly symptomatic on diuretic therapy. And so this is really an interesting time. And so patient selection is really the key here, and picking folks that you're going to be able to reduce their TR and feeling like you're going to get that benefit that you just saw from the quality of life standpoint. One of the things I'll just mention right away is that one of the things I talk about in the office even at the first visit when I'm evaluating patients is that everything we talk about these devices is about quality of life, not necessarily heart failure, rehospitalization, or mortality benefits, as you just saw. But I will say, I think Gil's point is very well taken, and I agree with this, that let's see what happens at 2 years and further out from there. Because I think we know that this is the latency to symptom onset and to poor outcomes for patients with TRs is, as Gil just said, is a lot slower. So I think that final story is not told, but based on the data we have now, I can't sit in the office and tell folks they're going to live longer or not and be hospitalized less as a result of this. So I'm upfront about that. And, you know, in structural interventional cardiology, our whole foundation is based on TAVR, right? So, and that's our bread and butter for all of us. And that's what we spend our time doing. And that's always going to pay the bills for the hospital, those types of things. So, you know, the TAVR foundation is built on hard outcomes. And so I was sort of molded in this mindset of hard outcomes. But I think what's really important, as we heard about throughout this session, is quality of life. And so when I sit with patients, I had an eye-opening discussion with a patient last week, and I got to that point where I'm like, look, this is not a mortality benefit. This is only quality of life. And I must have said it in a way where I was sort of downplaying that the benefit of that. And the patient was stopped me. I was like, why would I care about anything other than quality of life? I'm getting up in the middle of the night to go to the bathroom. These are the things that matter to me. And it kind of reframed how I was thinking about it to a large degree, that really does matter immensely, obviously. And of course, with the controversies that we talked about from a methodological standpoint. First, I will say that patients that I think at this stage of the game, when we're talking about quality of life, I think it's really critical to make sure you're selecting the right patients that have severe TR with symptoms on high-dose diuretic therapy. And I think we have to be careful not to deviate from that at this point, because it's easy to have creep in terms of indication here. And I don't think at this stage of the game with the data that we have, I think you really have to be really careful to that, and really making sure on your echo you're teasing out massive and torrential. So that's what we're doing in the office, is trying to select out those patients. I routinely do right heart catheterization on all patients that I'm evaluating for this. And I think it's really helpful because symptoms of TR often can be a little bit more vague and harder to pin down than severe AS, for example, where, you know, we know how those patients present. So, you know, a lot of folks come in, it's clearly they're volume overloaded on diuretics. A lot of folks feel just fatigued and, you know, sort of poor quality of life, that type of thing. And so I think it's really helpful to use the hemodynamics to sort of help support your case that you think that the TR is driving the picture. And then we work them up for both at our institution. And so all patients end up getting, right heart cath, a transesophageal echo, of course, transthoracic, a CTA as well. And so we look at all options. Now, if patients have CKD and cannot get a CTA, that may limit your options and move you more towards one approach or the other. But we think about all of those, and then we take into account each of the factors that Sajjad just went through in detail. And I think that those are all part of it. And so we say what's going to be the best option for each individual patient. We sort of have a preference to leaning towards TTVR at our institution. We have a lot of experience with it as well as with TTR, but we just sort of going on the concept that more TR reduction seems to be a better thing. And so that's our thought process. But of course, this is a moving target, and we're learning literally as we're going with this. And so I think it's a lot of important things. The other thing I will just mention from a procedural standpoint and a pre-procedural planning standpoint is that we admit all of these patients ahead of time, usually 2 days. My standard approach is I admit patients for right heart catheterization and IV diuresis 2 days prior to the procedure. We're doing two cases tomorrow and brought the patients in on Tuesday, yesterday, to do right heart caths and diurese them really effectively so that you can really kind of cinch down that tricuspid valve annulus and not have problems with sizing and be able to reach if you're doing a T-tier or grasp the leaflets if you're doing an invoke case or a full valve replacement. But sort of all of those going into effect, I think if you start a couple of points that maybe lean one way or the other. And I think that, that figure in JACC is very, very helpful. If you have, thank you. If you have leads in place and they're impinging on devices, that may steer you one way or the other. The pacer risk is real with TTVR. And, certainly a quarter of patients. And if you take out patients that had pre-existing pacers in the trial, the number's even higher. So I think it's closer to 40%. I have to double check that, but it's real. And you have to think about your strategy for that. We go with a coronary sinus lead, but that's something to take into account. If there are two leads there, how are you going to visualize it? Do you need intracardiac echo for that, which we're finding we need on certain cases? But kind of going through this criteria is very, very helpful. If they have really poor RV function up front, as you heard already, that's a factor that doesn't help quite as much, or track as well with outcomes. And so oftentimes I think a T-tier strategy is probably better than a full valve replacement because having, fully eliminating the TR, the ventricle might not handle that as well. So we're taking all those factors into account when we're evaluating these patients. So I think those are the main points I wanted to mention.
And Paul, can I just ask you to expand on one thing, which is, is there anything on the hemodynamics when you do a right heart cath that would make you second guess or doubt the approach in general? I think assessing the RV is very difficult. Echo does the best it can. But, is there anything that you look at similar to how patients for LVAD are often evaluated with a right heart cath? Is there any specific thing that jumps out at you?
Yeah, I mean, I will say if I do a right heart cath and the RA pressure's 2, that gets my attention oftentimes right up front. That perhaps that's maybe not the driving force here for their edema. That maybe we should be looking elsewhere from that. But that's sort of the one thing that jumps out. Obviously, we're looking at the PA pressures too, though, as well. Just thinking ahead to in the trials, the pulmonary artery systolic pressure greater than 70 was excluded. So that's an area that we don't totally know exactly how that's going to be handled going forward by the PA when you fix the TR in those patients. And so those are just some of the parameters that I'm using in the lab.
Great. Thank you, Paul. And Dr. Tang, if I could ask you one other question, you're the only one on our panel who is a surgeon, and I'm curious about your perspective on the role of surgical treatment of isolated TR. These trials, generally speaking, assume that a patient is not a surgical candidate, but surgery for isolated TR is, from my understanding, quite rare. So I'm curious, practically speaking, as somebody who's involved with both sides of this, how do you find yourself evaluating and counseling patients?
Yeah, no, absolutely. I think the great news, first of all, is that we have now 2 FDA-approved devices, percutaneously to treat TR that have been shown to be effective. So that really broadened the spectrum of options for treatment for these patients, which, as you have mentioned, have been undertreated because isolated TR for surgery carries multiple morbidities, not because of the surgery itself. It's actually a rather simple surgery, either repair or replacement, but it's the patient's comorbidities that really putting someone on cardiopulmonary bypass or even have to cross-clamp the heart at risk, particularly in the risk of bleeding risk, because they also have liver congestion, liver dysfunction, and acute liver failure or acute RV failure, as others have mentioned, from a surgical standpoint, which, there's really not a whole lot of options to bail out, even with mechanical circulatory support. And then, of course, as you mentioned before, the number of isolated tricuspid surgeries are done very rarely in the United States across, over 1,000 cardiac centers currently. So having said that, I think in certain expert centers like Mount Sinai and others, that I do feel that isolated tricuspid surgeries do have a role, particularly younger patients who are not as at advanced stage of their morbidities. And also at the same time, as Paul has mentioned, that there might not be a good transcatheter option available. So what I mean by that, either unfavorable anatomy or suboptimal imaging to do the procedure safely and effectively. And particularly in cases where there may be multiple CIED leads. We've seen those cases before. They are kind of in the way because the patient have multiple, hospitalization, heart failure, and advanced cardiomyopathy. So in those cases, we might still offer high risk of surgery with the understanding that they would likely need to have, prehab, like what Paul mentioned, admitted a few days prior to condition the right heart to undergo open heart surgery, but also at the same time stay in the ICU to condition the right heart after the surgery. So it's not just the open heart surgery itself, but it's actually the whole process, just like what you would do with T-TIR or TTVR. So we do offer surgery for these patients if they're not candidates for transcatheter options. And remember, as well, and the literature has shown that if you do repair the tricuspid valve through a transcatheter means, you want to achieve, as is shown in this trial, moderate or better TR or less TR. If you're left with that, a severe TR or greater TR, unless you've shown that you're more than 2 grade reduction, and the literature shown that it's not going to be, it's associated with suboptimal outcomes. So we need to really be mindful of that. And that's where Paul mentioned that the holistic evaluation and approach is necessary to determine which is the preferred and optimal and safe approach to these patients, because bleeding is not a good outcome for these patients given their morbidities.
Thank you very much. So in the interest of time, we're gonna move on to our chat-based Q&A. For anybody who wants to type a question into the chat, if you haven't already, please, we've gotten a couple, but if you haven't already, please go ahead. Just go ahead and put your name and training level and state just so we can track things. A couple of questions have come in already. Forgive me for looking off to the side here. But one question that came up, which was again about people who have pre-existing leads. How does that affect what you do? Do you have one of the questions maybe for Paul Fiorilli was, do you have EP come and participate in your assessment of the patient, or do you actually ever consider device lead extraction before doing this?
Yeah, it's a great question. It's something we're dealing with on a regular basis in these patients, and so we do have our electrophysiology colleagues, specifically at our institution. We have our colleague that does lead extractions is the member from the EP that joins us on these multidisciplinary discussions. We have not actually extracted a lead yet to facilitate it, but we've discussed it several times. And we've had some differences of opinions actually as we've gone through this, but trying to come to the best approach that we can. We have done several cases with 2 leads across the tricuspid valve. I actually saw a guy on Monday that has 3 leads across that we're going to have to discuss, which may end up needing to be a surgical case. I'm not sure yet. Definitely affects your ability to visualize what you're doing and can affect the ability for you to either grasp leaflets if you're doing a T-TIR approach or potentially curl underneath the leaflets with the TTVR approach. And we've had issues sort of with both, and you can have a little bit of leak in that area, which can be problematic. But definitely one of the risks that comes up when we're discussing lead extraction is if you have a lead extraction and you're complicated by a papillary muscle rupture or something along those lines, and you have a flailed leaflet, you may have eliminated your catheter-based option from there. And so we have been hesitant to extract ahead of time, and instead have been trying to work on strategies to treat with the existing leads in place and work around with the imaging concerns. Now, there is the theoretical risk of lead infection, and once that lead is sort of sandwiched in a spot, either behind a valve or nestled in there with a T-TIR in place, that if there is infection of that lead, which theoretically would be a 1% per year risk, that you may not be able to get it out. And so that's a concern as well. And our EP colleagues bring that up to us every time we discuss this. So that's a concern for sure. And I don't know what the right answers are. Some of the things you have to take into consideration when you're considering putting in a TTVR when there's a lead across is that there's enough slack in the lead so that you're not sort of pinning the lead too much where it could slowly work its way out or sort of micro regress out from the myocardium. And there's been a few rare reports of that as well. Well, yes, it's a discussion, and I think we're learning as we're going.
Yeah.
Great. Dr. Sabir, go ahead.
Yeah, no, I 100% agree. In part of that multidisciplinary team for this, you have to have an EP colleague who's experienced in lead extractions. And if you are going to extract a lead, I believe you should be using imaging to really appreciate and understand the interaction of the lead with the leaflets and subvalvular apparatus. If it's scarred into or fibrous into a leaflet or papillary muscle, as Paul mentioned, you have to rethink the possibility of extracting that lead. If it's really mobile, you can make a really fairly good assessment, which one is going to be an easier or relatively safer one to extract. If it's not interacting with the leaflet, it's not stuck to the leaflet, and the TR is not where the lead is, I would preferentially use edge-to-edge repair as an option, because you don't have to extract the lead. You just simply work around it if the TR jet is not where the lead is.
Dr. Arnold, I think this one is going to be for you. There was a question saying, given the prevalence, these trials were majority women. And so the question was, were there any sex-specific outcome analyses that were done in any of these trials? Is there any evidence of a heterogeneity in effect by sex?
I mean, none of the studies showed any interactions in terms of bisex. Certainly, there was a predominance of women in both trials. But I think that you could theoretically start talking about, three-way interactions by, sex and severity of TR, and that might be an interesting study to look at if you're talking about sex-based. But at least in the first look on both studies, there has not been any sex-based differences.
And maybe another question for you as a trialist. Somebody asked the question of, are there going to be any studies looking into the economic impact of these, or the cost per quality of life year, et cetera? Are there any? As far as we know, nothing has been published about that. Is that something that's looked into?
Yeah, nothing that is known that I know of that is being planned. Certainly, I think that would be interesting. A lot of those types of studies tend to be very driven by hospitalizations, and so when you don't see any impact on hospitalizations, it's going to be a bit challenging to see any differences besides the initial hospitalization costs with the device. So I'm sure somebody will do a model based, but it would really be, I think it'd be interesting to do a trial based cost effectiveness as well.
Actually, related to that, one of the other devices that's still undergoing trial, Class 2 TR trial, they are capturing healthcare economic data as part of the trial. So you will have a better sense of that from that.
Yeah, and I think you could easily do it with, kind of CMS data. Most of these patients are older, so it would be pretty easy to do. I don't know how much that's going to inform policy.
Question for you, if you don't mind, Vivek, and actually also for Gilbert and Paul. Do you think part of the reason we're not seeing mortality benefit yet, of course, perhaps you have to wait longer, also it's possible that the studies were underpowered as well, because we didn't really have as many heart failure outcomes as you assumed as part of the sample calculation. But also, it's all atrial functional TR in both trials that we're treating, right? It's not a mixed bag. And we know atrial functional TR overall, mortality is not as bad as the other etiologies. Do you feel part of it might just be related to the etiology?
Dr. Tang, maybe, do you want to talk about that?
I mean, yes and no. I think it is a mixed bag. If you look at the demographics of the TRILUMINATE trial, about a third of the patient had left-sided disease, had prior, left-sided surgery or intervention. Yes, there is a group of atrial secondary TR. We haven't quite do any subgroup analysis to pass all the differences where there have any heart endpoint or hospitalization endpoint or KCCQ difference. But you're absolutely right. 90+% of these patients have underlying atrial arrhythmias. So the question is whether, addressing the atrial arrhythmia will help these patients. And this is the same issue of atrial secondary MR, right? Not just TR. So the unfortunate part of that, a lot of these patients have permanent AFib. And so, and we know that, ablation therapy alone is not going to be, perfectly efficacious. But having said that, you're absolutely right. We actually work with our EP colleagues, not just in terms of lead extraction and lead management for these patients, but actually talking about, is there any role for rhythm management or rhythm control for that matter, before or after tricuspid intervention. And we find that that is absolutely necessary to do to be able to sustain some of the benefits of tricuspid therapy, at least in our mind, because we have seen, at least in my personal experience, having done these procedures, that, yeah, you got a good result acutely and procedure maybe in 30 days, but without treating the arrhythmias, the endless progressive dilate, whether it's the mitral side or tricuspid side, and then now the TR returns. And so this is a very, unsatisfying, experience with the patient and family, and of course the primary cardiologist, and us. So I think we still have a lot to learn and a lot to do, in fact, to try to optimally manage this patient, not just with this GDMT, but also rhythm management, which I think has been underappreciated and under-discussed.
Thank you very much. So unfortunately, that's going to take us to the end of our time, everybody. It's been a pleasure. Thank you again to everybody on our panel for participating. I think this has been a great discussion. Thank you, Megan, for putting everything together. And one quick plug, the next session of our JACC Journal Club is actually going to be live in person at ACC 25. The date and time information is there. It's on Sunday. We have a space at the Lounge and Learn Pavilion. We have not announced yet what topic and what speakers, but we hope you guys can join us there in person. Please mark your calendars now. Thank you again to everybody for joining, and hope you had a good time. As I said, this session will be recorded and it will be available on the JACC Journal Club website. So thank you again to everybody for coming, and have a good night. Thank you.